Good afternoon. My name is Honggang YU, come from Renmin Hospital of Wuhan University. The topic I would like to present here is research advance of AI in GI. Here I would like to thank a lot for Professor Philip Cho to invite me to participate in this wonderful conference. And I feel very proud and honored to make speech in Wales Prince Hospital's International Conference. As we know, artificial intelligence have already developed very fast. It all covered almost every field of the endoscopy. Here, I would like to introduce our product and engine. And I would like to introduce some new progress in the artificial intelligence in gastrointestinal endoscopy. So the special things for an engine is first we focus on the quality control, and then we go ahead to detect the lesion in GI tract. First, I would like to introduce the application of an angel in EGD. So the first function, in fact, many people feel familiar with this function because last 1 year I have already introduced this function many times. So we just divided the stomach into 26 parts, and then we monitor the endoscopist detect all parts of the stomach. So this is really very important, and our multi-center RCT has already confirmed this the importance of this function. You can see here an angel can largely decrease the blood spots just caused by our endoscopist. The second function is automatic photo documentation. So here our data show that an angel can make better photo documentation than endoscopist. So as I said, the principle of an angel is to first is quality control, and then detect the lesion in GI tract. So now I think the most challenging for GI diagnosis is early gastric cancer. So here we developed the function to detect the high-risk lesion on the white light. So you can see the square just show you the location of the lesion. And then if the square became red, that means this lesion is high risk of neoplasm. So you must go ahead to do magnified endoscopy, MBI or BLI. So under the MBI, you can see here, we also developed the function to make the judgment or assess the characteristics of this lesion. So here, if the square became red, that means this lesion is a malignant lesion. So just means early gastric cancer. After make the diagnosis of early gastric cancer, maybe if you want to do ESD, you must mark the margin, and an angel can also add this prediction to novice endoscopists before they make the ESD. And an angel can also assess the depth of GC lesion in white light. So you can see under the white light, an angel can predict this lesion is located in just invade in mucosa layer, and this one is much deeper, just invade the submucosal layer. Maybe should go to do surgery. The sixth function is to identify differentiation status and delineating margin of EGC, ME, MBI. So you can see this lesion is, and angel think that's a differentiated lesion, carcinoma, and the margin. They also show the margin or the demarcation line. We also developed the function to identify the type of early esophageal cancer and examine the depth of lesion. So all these function based on the AB classification from Japan. And we also make diagnosing the esophageal varices and gastric varices, but we only predict the risk for early bleeding. So if the very high risk for early bleeding, maybe you should go ahead to do therapy, for example, the EVL or EIS. So this figure just show we have already developed quite a lot of model, and these models cover almost all lesions in upper GI tract. Now I would like to introduce the application of an angel in colonoscopy. So just similar to that in EGD, in colonoscopy, first we assess the bowel preparation. So you can see this function also based on the Boston scoring, but we showed in real time and in percentage of the whole colon. And we found very interesting things. The Boston scores, the most important thing is the score 1. If the score 1 cover only less than 15% of the whole colon, that means the preparation is not so bad. But if more than 15%, that means we must reduce the bowel preparation and should reduce the colonoscopy in nature. We also developed the quality control, just make sure just want to assure that endoscopists did a good colonoscopy operation. So you can see there's a dashboard. The pointer point if the pointer point green zone, that means your withdrawal speed is perfect and smooth. So you have good opportunity to observe or detect the small or minor polyp. But if pointer point the red zone, that means your withdrawal speed is too fast. You must slow down. And we also have the function to detect the polyp and make the classification if that it is adenoma. We have done a very good result. So this result I want to share with you guys. We have organized a clinical trial. Just there's a two factual trial. So we have 4 groups. The first group is a control group, blank group, and second is quality control group, and the third one CADE. The fourth one is combine the 2 function. So I show you this result. I feel really like this result. You can see in the control group, although my colleague withdrew the colonoscopy more than 6 minutes, but only can achieve 15% of the ADR. But CAD can largely improve the ADR to 22%. but quality control even increase or improve more than CADE function. But if we can combine the quality control and the polyp detection, these two functions, we can even double the ADR just compared to the control to 31%. That's really wonderful result. So the sixth function, we also delineating the module of 2B plus 3 lesion feature in the MBI. This is just for the genetic classification. So we want to use it to make the clinic doctor or the endoscopic more convenient. So the third thing I would like to introduce application of an angel in pancreatic biliary tract. So you can see the first one is just the 6 stations scanning of pancreas. So that's the voice, Chinese voice of instruction. So the first is identify station during endoscopic ultrasound scanning in real time. The second is perform real-time segmentation of pancreas and the landmark blood vessels. And we also have the voice instruction for the endoscopic operation. So that's really very like the GPS navigation. Now I would like to show you for the bioduct. Bioduct is 4 stations systems, so it's also similar to that in pancreas. But now we want to show you the content or the range of the bioduct. You can see the blue line show the bioduct, and we can see the size of the bioduct. So the last one is the application in ERCP. This function is similar compared to other functions. This only for the novice endoscopists. We give them the suggestion, just the technical difficulty scores. So and we also give them the suggestion if this patient maybe just like this patient should do the EST, EPBD, or lithotripsy, and the balloon size for enlarge the polyp should less than 10 millimeters. The final function is application of angel in quality management. So this software just on the basis of an angel. So other functions. So with this function, we can know all my colleagues as a chief of the department. I can know all my colleagues' quality parameters or how the amount of their working. So last year I have participated quite a lot of conference, and even in end club note, Professor Thomas Roche has made the live demonstration of an angel just in his important conference. And that's the conference I participate in this year, also including the West Prince's Hospitals International Conference. So I have already got 2 patents from our government. Just only use 2 years, I got 2 patents, and now we have applied the patents in Europe and the United States. That's the publications during last 2 years. We have published 4 endoscopy paper, 4 GIE paper, 1 gastric cancer paper, 1 gut paper, 1 LGH paper. Now we have another 5 papers on the review by several journals. Thank you very much.